Michael, are you going to be able to, there you are. Okay, so you'll stay for the, it's good,
Yes.
good to see your face. How are the children?
6 years old. We started elementary school, yeah.
Oh, congratulations. Have a seat. Okay. So we'll just take off. I don't know if you'll be able to hear the questions from the audience, but if you can't, I'll direct any to you, okay? So let's take the first one.
Hi, Fariba Donovan again from University of Arizona. I have a question for Mihalis regarding the C3. We have some unpublished data on the disseminated cocci that shows lower level of C3 expression in disseminated, mainly cocci-meningitis. Do you have any data on C3 expression in your recent studies, or do you have any comment on that?
So I didn't show data on C3 and Candida. I mean, if you take C3 deficient mice, they are equally susceptible to candidiasis as C5 or C5 receptor knockout mice are. I think that there are ongoing studies, preclinical studies on cocci and complement. I think it's mostly on C5. I'm not aware of data on C3 and cocci in mice. But I think your question is important for the fact that there are not only C5 inhibitors or C5 receptor inhibitors in clinical practice, but there are now C3 inhibitors as well. And because C3 is upstream of C5, in many situations, one could potentially postulate that the effects of C5 might also be seen with C3. So I think for Candida, for example, the functional defects appear to be similar. The induction in patients and in mice appears to be similar with C3 and C5. Have we looked, if you're asking if there are C3 mutations in cocci patients with severe disease, I don't think that came up, but you know, we can certainly look, and you can email me and we can directly look back to you. But I think with the advent of eculizumab, the advent of avacopan, the advent of C3 inhibitors now in their trials on periodontitis, I think we will see fungal disease. The question is whether that will be seen in conjunction with corticosteroids, as it happens in TNA, for example, or it would also be lower level infections even in people who just get treated with C3 for periodontitis, for example. I think that needs to be determined.
You know, one additional point I wanted to make is patients who have SLE, they have lower level of C3 and C4. And these patients are, some percentage of them are African American. And we see that higher risk of disseminated cocci in African American. So I've been thinking about potentially using that as maybe biomarker in these patients to consider them as higher risk for disseminated cocci in our area, which is endemic for that.
I think if you have samples, this is testable. I mean, the data in C5 levels and Candida in the ICU are pretty compelling. And I think if you have cocci and cocci negative controls and availability of samples, this is a great question to ask, and it could be useful if it is indeed a biomarker.
Okay. Jessica?
Thank you. I'm Jessica Little from Brigham and Women's Hospital. This is for both speakers. Thank you so much for your talks. I think one major issue that we've seen is with this explosion of small molecules in the oncology field, that in the clinical trials, opportunistic infections are often not clearly tracked, and in particular invasive fungal disease. So a lot of these risks are found later on in real-world studies. How do you think we can address this issue moving forward?
Demetrius.
I'm in the middle of this right now because I'm part of the advisory board of venetoclax azacitidine versus azacitidine placebo for MDS. And the fungal risk, I'm the only ID person in the DRC, and the way infections are coded is sepsis, fever, pneumonia. And I keep asking, what pneumonia? Pneumonia, there are 50. You say pneumonia. So the oncology people don't have the urge or the need to characterize infectious. And then if you ask to get a downstream analysis of those data, the data are not there. The studies are very expensive to begin with, and I don't think this is it's a big problem. But I'm dealing with this every time. I said, what do you want me to say in this advisory board? I mean, pneumonia? And yeah, it's a very systematic omission for all these studies.
Mikhail, do you have any?
I would agree, and I'd say sometimes it's even worse. I think some of the earlier studies in some of these biologics just had infection. Whether that meant you had a
That's helpful.
rhinovirus or brain fungal infection, it didn't quite matter. I think we've discussed this to some degree in the context of IDSA as well, and this might require agencies from infectious disease to our community also at MSG raising more awareness. I don't see an easy way out of that because there is, as Dimitri said, there's not much of interest in these early studies to pinpoint the problems. But I think it's also impossible to go forward with just saying you had an infection and not specify what that meant.
Just to give you a little bit example of how oncology trials are done. It's very informative for me because I've never been in a DRC of an oncology compound. So they say end of treatment response, survival, sepsis, febrile neutropenia, heart attack, multiple organ failure. So they categorize all these non-competing, non-oncology cause of death to a bucket. And because all of them are very uncommon, as a background, by itself doesn't give a notoriety. But they say, okay, supportive care related death. And typically these people don't have an autopsy, which is another major problem. So sort of the companies be a mandate characterized infectious death, because even with ibrutinib it's 3%, 5%. What is the threshold of acting is a complicated question, but I think we should push as a community as more drugs are introduced.
Thank you.
Okay. Let's see. Peter and then Tom. Peter?
Yeah. Hi there, great talks. Hillis, you saved yourself a long flight. Great talk. I have a question, sort of general for both. So we're in the wild west of immune modulation. I'm having a great time. We're throwing new drugs at people. They're having dramatic results. People are waking up from comas. It's great. But coming back to John Perfect's question is, what kind of biomarkers should we be coming up with to properly modulate the immune response? We know that PD-L1 inhibitors have been associated with graft versus host disease. You certainly don't want to be giving people with stem cell transplants, just with wild abandon, a PD-L1 inhibitor. Mihalis, I know you've done some work using CXCL9 as a biomarker to kind of follow. Where are you going with this, and how do you think this should lead us so that we properly do this and not just kill people different ways?
Demetrius. Oh, that's okay.
Mikhail,
go ahead.
Yeah, I think that, Peter, that's a phenomenal question, and it's right on target. I think the answer is not simple, and I don't think there's going to be one set of immune parameters that fits all. So I think what is the defect in ibrutinib-treated patients is very different from what the defect is in someone who got pheohyphomycosis or someone who got mucor. So I think we need to better understand immunity. So I can tell you for ibrutinib, for example, it's really neutrophilic dysfunction, and there are assays that one can do, and those could potentially, the degree of impairment could actually help, but whether that would apply to garden variety non-ibrutinib associated aspergillosis or mucor, it is not possible, I think, to put everything together. So I think the answer is to continue understanding the pathogenesis, the immunity, and as we understand more of that, I can also envision that there could be common themes, but I don't think that there is going to be one that fits all. So for crypto, for example, or iris, I mean, you've shown very clearly also in the CSF how different the immune response is that is in the blood. So, if you take that parameter into account, that, if you're dealing with a CNS infection, getting something in the blood might not really portray fully what's happening. I think that adds another layer of complexity. So I think it's a great question. I think we know more than we knew before, but I don't think we're very close to having a biomarker that fits a lot.
Yeah, and I would agree. I think we're going to touch on this important question in the afternoon. Sebastian is going to talk about some early ideas and findings we have in some of the mouse model of checkpoint inhibitors. As I said before, we learn it's context-specific and fungus-specific from the checkpoint inhibitor work. But the other thing I want to point out to you, another gap in, need is to the importance of controls. For example, I have written a letter to the editor in the past because I couldn't handle myself of not doing it. There was a paper about aspergillosis and cytokines as predictors of aspergillosis, gamma interferon, blah, blah, blah. And if you go to the literature and see what do you know about the cytokine milieu in leukemia without aspergillosis, there is already a derangement based on underlying disease. There was a point about CLE, rheumatoid arthritis. What do we know about the immune perturbation of rheumatoid arthritis if they get steroids or disease-modifying agent? I think as we develop biomarkers, the importance of careful controls is going to be very important to validate this biomarker. Otherwise, it's going to be all these outliers that maybe lead us to the wrong path.
We have time for one more question. And so, Tom Walsh, who do you want to address yours to?
So, first of all, thanks to both presentations, both speakers, outstanding work. But Mihalis, question. We see in otherwise healthy infants or those that are very low birth weight infants, hematogenous candida meningoencephalitis. We see in CARD9 deficiency, unexplained phaeohyphomycosis. We see now with Dectin, the CNS as being an unexplained target. Why is it across these different populations, or what hypothesis can we generate to understand why the CNS is a target? And I would also add erbutinib as well, totally unexpected. What is a unifying hypothesis, if at all, that could explain why CNS is a target?
Great question, Tom. So in the context of CAR9 deficiency, the defect is in microglia that don't get activated properly. And those are the cells that actually are the danger alarm, if you will, cells to bring neutrophils in for control of the infection. So I think in the context of that uncommon but very informative inherited disease, it's a resident macrophage in the CNS that really drives that. That generates the hypothesis with regards to the neonatal candidiasis that you mentioned, which is a very important clinical entity. Now, I'm not a pediatrician, but you are, and many others are, and it's a very, very dramatic, indeed, entity, especially in low birth weight neonates, where you have a bloodstream candida. It's almost always in the CSF, and that outside of CAR9 deficiency, it's exceedingly uncommon in adults. The hypothesis there, we haven't yet conclusively tested this, but it's testable, is that that pathway of C-type lectin receptor CAR9 signaling might be mature in that very early phase of life. There are data immunologically that microglia do tend to be more immature, especially in low birth neonates. It is also true that in the context of that project that, again, we haven't yet conclusively shown data to share with you. But if you take, in consultation with Texas Children's, when we discussed this entity, they were telling us that, based on their chart reviews that they did with us, is that when you have low birth weight neonates getting strep B, for example, meningitis, there is mobilization of neutrophils in the CSF. And when they have candida, it's almost never that they have neutrophils. So that is not inconsistent with that hypothesis, but we have to test it, and the way to test it would be in neonatal mice. So I think that could be fitting the C-type lectin, Dectin-1, other Dectins, CAR9 paradigm. Now, with ibrutinib, the answer is we don't know yet. I think we understand more with regards to why they get aspergillus, and there's clearly neutrophilic defects. We haven't published yet that story, but what I can share with you is that you give ibrutinib for a day or two in an individual, and their neutrophils get severe defects in how they handle Aspergillus. Does this explain the CNS? I don't think that's the only defect. So the question there is whether microglial defenses also rely on BTK, and that's a direction that we're embarking on, but we don't, again, have data yet. Whether the mechanism will be similar, is BTK and CAR9 aligning? To some degree, SIK and BTK do align, so whether there's going to be a unifying pathway at the very end, it is possible, but we need to complete the work before I can conclusively.
Michali, a very quick question because of the interest of time. Do you have any comments about strain-to-strain differences in CNS tropism, and are we seeing this thing only with the lenses of immunogenetics, or should we pay a little bit of attention about affinity of specific strains to CNS?
That's a great question, and we often forget that, and we shouldn't. So what I can tell you is that if you take different Aspergillus strains and infect BTK knockout mice, some strains will kill the mice and some strains will not kill the mice. And it does align that Aspergillus strains that we have captured from patients who developed ibrutinib-associated aspergillosis, so clinical strains, always kill the mice. But laboratory strains tend to not kill aspergillus. So where exactly the adaptation occurs and what that adaptation is, I mean, with Rob Kramer, we started doing whole genome sequencing on aspergillus themselves. You know, it's probably going to be difficult with a few strains to discern what the problem might be. But you're adding an important dimension, that is the fungal strain properties can also play a role. And that's a dimension that is always important to take into consideration.
Mikhail,
They might explain the low frequency of ibrutinib-associated aspergillosis in monotherapy, which is probably not more than 2 or 3%.
Exactly, this is where I was going to. Yeah.
Mikhail, thank you so much. Thanks for taking your time to join us. Sorry you can't be here in person.
Thank you again.
Have a great day. Okay.